Okay, thanks for joining today's NCCN webinar for patients on multiple myeloma. I'm John Murphy with the Patient Information Group. NCCN stands for the National Comprehensive Cancer Network, which is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. The NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars like this one. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines, which are used by healthcare practitioners worldwide. The guidelines for patients explain the same options for cancer care as the clinical guidelines, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients on the NCCN website. Printed copies of the book can be purchased through Amazon. NCCN webinars for patients complement the NCCN guidelines for patients. And during the second half of this webinar, you'll have the opportunity to ask questions to our expert presenters and hear their answers. We have three great presenters and they have three excellent presentations. So if you're tuning in today, you picked the right webinar. So our first speaker is Dr. Christopher D'Angelo. Dr. D'Angelo is an assistant professor, hematology and oncology at the University of Nebraska Medical Center. He's also a member of NCCN's clinical guidelines panel on multiple myeloma. Next, we'll hear from Jennifer Schmidt, a registered nurse who is a multiple myeloma transplant case manager at the Fred and Pamela Buffett Cancer Center at Nebraska Medicine. And our third presenter today is Gregory Proctor, who is an entrepreneur, podcaster, and author, and a multiple myeloma survivor and patient advocate. All right, let's get started. Dr. D'Angelo, please take it away.
All right, well, thank you, NCCN, for the opportunity to speak, and thank you all for joining us today. So the title of my talk is What to Expect When You're Expecting CAR-Ts, and I've got a little cartoon here showing a myeloma cell and then the CAR-T cells kind of ganging up, gearing up to fight them, so to speak. And I like it because I think the myeloma cell looks a little scared if you look at those eyes there, and I think it should be after we get done talking about, how these things work. So basically, an outline that I wanted to show here is just starting with some basic definitions of T cells and CAR-T cells, and then breaking it down as far as a timeline on what different steps happen along the way for CAR-T cell therapy. And I'll go into all of these individually, as well as expectations and guidelines at each step. So first, some basic definitions. You may all already be aware of this, but where these CAR-T cells come from are our own T cells. And a T cell is an immune cell in your body, a lymphocyte, and there's actually two different kinds of them. A B cell is a myeloma. A B cell makes antibodies. It responds to our vaccines, and it's an important part of our immune system. But it can turn into a cancer like any cell in our body. And actually, the myeloma cell comes from a type of B cell, which is called a plasma cell, and that's kind of the differentiated end form of a B cell that makes all those antibodies. And that's where that protein in myeloma comes from that you may hear about. T cells work to fight infections naturally in our body, and HIV is a good example of a low T cell disorder and infectious complications that come from that. But T cells do more than just fight infections. They actually can be kind of the police on the street, so to speak, for surveilling and monitoring. And if they ever see some cancer cell populations coming into the body, they can actually treat and destroy those before we're ever even aware of them. So they have some kind of natural anti-cancer properties to begin with, and CAR-T kind of takes advantage of those. So a CAR-T cell is basically an engineered T cell designed to target a marker, also known as an antigen, on the tumor. So CAR stands for this chimeric mixed antigen receptor, and it's a chimera, if you're familiar with the term, has kind of different animals kind of hodgepodge together into one animal. And so a chimera or a CAR here basically takes a old receptor on the T cell that activates the T cell and then fuses it to a new antibody kind of recognizer that binds to a marker on the cancer cell. And the marker that we use in multiple myeloma is called BCMA, in case you are ever hearing that term come up. On the right of the panel here, there's some steps along the way of how CAR T cells are prepared. The first step being leukapheresis, which is just our fancy word for collecting those T cells, a very similar process to stem cell collection if you went through that. After that, they get sent to the company to manufacture. And so here they're engineered with a virus that kind of encodes that CAR receptor. And as you can kind of see on the right side there, once they express that receptor, they are expanded, grown up to a sufficient number. And then they're tested to make sure they actually are going to do their job when they go back in. And then they're sent back to the cancer center and they're infused. So who's eligible for CAR T cell therapy? Well, for multiple myeloma, currently it's if you've relapsed after 4 or more prior lines of treatment. And I have some asterisks there because CAR T cells are being studied in earlier settings. And I suspect in the not too distant future, they're going to move to earlier lines of therapy. We're so happy with how these treatments have worked for our patients that we want to make sure that we're getting them kind of earlier and earlier on. The other part of it is we want to make sure you're fit for CAR T cell therapy. So even though it's generally a lower bar than stem cell transplants, so if someone was telling you that maybe you weren't fit for stem cells, you may actually be for CAR T cell therapy. Pound for pound, it's typically less toxic, though some significant and severe side effects can show up. So what are the CAR T cell options that we currently have available? Well, we have 2 FDA-approved CAR T cell therapies currently. Cilta-cel, or also known, the trade name of that is Carvykti, and ide-cel, with the trade name being Abecma. Both target BCMA on the myeloma cell, and the treatment process and the steps that I'm outlining here are very similar for both products. Now, importantly, cancer centers have different access to these therapies, and until recently, waiting lists were required and may still be required depending on what site you're at. Overall, I would say access really is improving, especially for ide-cel, which has a little bit more production capacity, though I'll mention that both cell lines and treatments are increasing their production capacity to make it more and more available for our patients. So, importantly here, the best CAR T cell therapy is the one that you can get and the one that your doctor is recommending for you. Both of these different treatments, although they work very similarly, do have slightly different kind of effects and procedures. With Cilta-cel, for example, there is a slightly more higher risk of manufacturing failure, meaning they collect the cells but aren't quite able to make them. A slightly longer manufacturing time, and there is a slightly increased risk of some neurotoxicities with Cilta-cel. Some Parkinson's kind of features have been observed several months out from receiving that therapy, though that is incredibly rare. Very importantly, in case you're wondering if one is better than the other, ide-cel and Cilta-cel have never been compared head-to-head. And so it's really not clear if one is better than the other. And importantly, both offer unprecedented outcomes for multiply relapsed patients. This challenges this paradigm that maybe you've experienced or seen friends or family experience, where each response to your current line of treatment may not have been as effective as the one before that. This is a moment where CAR T cells can kind of step in and say, not so fast, because they really have worked impressively well for our patients in this setting. Although individual trial data shows that there might be some better responses with Cilta-cel, we really don't know that, and I would caution any interpretation along that line, because we would really need head-to-head studies to truly compare. Trial data can be misleading, even though they are recruiting similar patients. It's not necessarily the same, and slight differences in who's recruited and how the trials run can translate into slightly different outcomes, which is why it's really hard to say, unless they're compared head-to-head, which one works better than the other. At the end of the day, for example, at the University of Nebraska, we use both. And honestly, we have seen successes and failures, unfortunately, with both. Which takes me back to my first point: the best CAR T cell therapy is the one that you can get and the one that your doctor is recommending for you. So once you've decided to go with CAR T cells, this is a little cartoon I kind of created for this talk, where I separate this process into sort of 2 time periods: the brain to vein time, and then the vein to vein time. I have my partner, Dr. Lemming, who does lymphoma CAR T cell therapies, to thank for the brain to vein time. So I can't take credit for that myself, but I like it, and I think it's a really nice kind of organizational tool to understand our different steps here. So brain to vein time, basically showing this cartoon on the right here, it starts when your doctor and you have decided that you want to proceed with CAR T cell therapy. So what's different about CAR T cells, if you've selected a different regimen, your doctor's thought about a different regimen for you, usually you can administer that within about a week or two of therapy of making that decision. But with CAR T, there is a several kind of week-long procedure that happens. And the first steps typically that happen are some sort of check-in, making sure, some fitness testing, checking your heart, things like that, and insurance authorization. This can take time, and differing time depending on each insurance, and each center is a little bit different on this, so it's hard to give you an accurate number on this. Typically what we've seen is Medicare can often be faster and private insurance slower, but there's certainly exceptions to the rule across the board there. Once that's been achieved, and that can take several weeks, the next step is to schedule a collection appointment, or apheresis, which is our fancy word for that, and a line or catheter would be placed to help collect those cells. As I mentioned, you'll undergo a pre-CAR T evaluation, and ultimately you and your doctor will help figure out if you need any interim treatment to control the disease during this period, because it does take a little bit of time to get ready. So who needs treatment in the brain to vein time? Well, I would say I kind of think of this as someone who's got symptomatic disease that we really kind of need to control to put you in as good of shape as possible ahead of CAR T, or for rapidly growing disease, where if you don't have symptoms, we certainly want to do our best to kind of prevent them from happening. Now, it's kind of a double-edged sword here, because we also want to make sure you don't develop toxicities or side effects from these treatments in the meantime, because we know that getting you to CAR T and getting those CAR T cells will work and have a very good chance of working. So our goals of interim treatment are to, number one, avoid toxicity, avoid side effects. We don't want to do anything that damages you or harms anybody going into CAR T cell therapy. If we haven't collected those CAR T cells yet, we also want to avoid damage to the T cells. We don't want to do anything that weakens how well they might work. We want to control the disease, and most importantly, too, we want to palliate symptoms. We want to make sure you're feeling as good as possible going into CAR T. So options for treatment, I would say I tend to think about this as it's not a one-size-fits-all. It's definitely personalized to you and what your doctor thinks will work best in this situation. Any agent not previously used is potentially an option. Radiation, if it's localized disease, can be a very effective option. We try to avoid that BCMA kind of targeted therapy, because we don't want to do too much targeting of that same thing that the CAR T cells also target, and give the myeloma a chance to kind of get smarter. We don't want any of that. And if we can avoid chemo, we will, but sometimes there's options where it absolutely makes sense. So moving on to the bridging period, or also known as the vein-to-vein time, the first step, just looking at this cartoon on the right, is that apheresis. And then you'll undergo CAR T cell manufacturing. So nothing that you're doing here, your cells are going off to the manufacturing company and being made in that first cartoon that I had shown, where they grow them up and test them and things like that before bringing them back and infusing them. During that time, you also have this option for potential bridging therapy. And during this time, there's a couple of events that might happen. One of them during the CAR T manufacturing step is a risk of manufacturing failure. It's a risk for both products, maybe slightly higher for cilta-cel currently, but I can tell you that these companies are actively working on reducing that and getting better and better each time they do it. So if you're told that there was a manufacturing failure and they weren't able to make them, one, it's not your fault, absolutely not at all, and it's just something that can happen just in the process. And you might have the option to recollect if your doctor is recommending that for you. You might have the option to try another therapy. So if your doctor is concerned about whether or not collection or manufacturing will work, they may recommend trying something different. Or you might have the option to infuse those cells under what we call an EAP protocol. EAP stands for Expanded Access Protocol, and it's a way of using these cells. Basically, if the company says, we think that these work really well, but they don't quite meet the FDA product label for cilta-cel or for ida-cel. And if the doctor thinks, I think that these are going to work too, and I worry that there could be some harm of recollecting and waiting around, and I really would rather use these, there's an option if that EAP protocol is available at your center, and if your doctor is bringing it up, it's often a great way to deliver those cells safely. I tend to think of this, the analogy I use, and Jenny's heard this too many times at this point, so if you see her rolling her eyes, it's understandable. But I say, if you've ever heard that expression, champagne is champagne only if it's grown in the Champagne region of France and everything else is just sparkling wine, I would say to that, well, heck, sparkling wine tastes just as good and sometimes even better. I tend to think of this as sometimes a sparkling wine of this kind of treatment. So don't be discouraged if you're recommending, if your doctor is recommending an EAP protocol, because it may taste as great as just as even better than champagne. This CAR T manufacturing period can take about 4 weeks, and any options for bridging therapy in this time are very similar to what I had just discussed previously. The only difference here is you don't have to worry about those T cells anymore because now they're on their way towards manufacturing. Or you don't, in general, have to worry less so about that. So once CAR T cells are infused, you have 3 days of lymphodepleting chemotherapy. This is basically given to kind of help prepare your immune system to make the CAR T cells work better. Most centers after that, once they're ready to infuse the CAR T cells, will hospitalize patients to monitor for side effects. But not every center will. And if they've worked out a protocol to keep you safe as an outpatient, so much the better. At University of Nebraska, our practice is to hospitalize patients typically for 10 days or so, longer if there's any side effects show up, so that we can just best appropriately care and monitor and react to toxicities and side effects faster. As far as post-CAR T cells, we're monitoring for some key side effects, especially while you're in the hospital, something for cytokine release syndrome, neurotoxicity, low blood counts, and infection. So cytokine release syndrome is like having an infection without an infection. It's an effect of the CAR T cells killing the myeloma cells and varies in low grade with maybe just a fever to higher grade with very severe side effects, low blood pressure, maybe needing to be in the intensive care unit. Nowadays, we have very effective therapies to treat these. So don't worry if it shows up because your team is going to be very well equipped to take care of it. Another thing that sometimes comes up is patients don't feel any side effects, and then they're wondering, well, heck, are these cells even working, or do I need to be worried that this isn't going to work for me? You do not need to have cytokine release syndrome for CAR T cells to be effective. That is kind of an overactive immune system and not necessarily a good thing to have. They're working, trust me. You don't need to have that side effect for them to be working. Neurotoxicity often will develop after CRS and kind of shows up again in different grades, maybe some minor cognitive changes, kind of mild confusion, words lost on the tip of your tongue, to bigger issues like just not knowing where you are, being confused and completely confused. Advanced grades are rarer when we use myeloma CAR T cells, and we have increasingly effective therapies. Monitor you closely with scores and checks every day, and if it's happening, we're ready to treat. Low blood counts are an effect of the chemo and the CAR T, usually observed in the hospital, and begin to recover at discharge, but mind the double dip. So your counts can go down and then come up, only to go down again. That's an effect of the CAR T and usually wears off over time. Rarely, some of the cytopenias can be a little bit more severe and patients can be transfusion dependent. If you have prior stem cells from a stem cell transplant that they have never been used, you can talk to your doctor. Your doctor may recommend using them to help boost those counts up. But again, that's pretty rare, and I tend to quote patients about a 5% chance of that happening. Infections are common, but rarely severe. I've separated these into different panels. The top right one with bacterial infections tend to happen more and within the 100 days of CAR T cells. Viral infections can happen anywhere throughout the first year after CAR T. Fungal infections on the left there are really rare and usually happen after 100 days. But not a very common thing at all, and usually a consequence of other therapies. If you developed neurotoxicity or something and needed extra therapies to calm that down, that can increase your risk of these kinds of things, and your doctor will be mindful about that. Immune recovery takes time, and you have different components to it. Sometimes the analogy I use is your immune system is like the military, and it's got different branches to it, and those branches will recover at different times, not just the number, but also the function. That helps guide our vaccine strategy, antibiotic use, and some of the socialization recommendations we'll provide for you. Follow-up schedules will differ depending on what your team's recommendations are. Importantly, you can't drive for 8 weeks after, and usually they want you kind of within a couple-hour radius of the hospital until you reach 28 days. Well, I'll skip that slide and just get to my summary here, which is CAR T cells for myeloma are a game changer. They offer time-limited therapy in relapse disease. So after you've received CAR T cells, that's it. It's a one-time infusion. and the first time for many myeloma survivors in years that they haven't needed to be on continuous therapy. They do take time to prepare, though, and that's that brain to vein time and that vein to vein time. And your doctor may come up with different strategies to control the disease and ensure they work as well as possible. Only the beginning of these types of therapies. So thank you so much. And I'm going to pass it off to my colleague, Jenny.
Hello, everyone. Thanks for your time today. We're going to talk about stem cell transplant and things for you to know to make you the most successful. Thinking about going into transplant, there's a lot to do to get yourself ready. All of these things start about the time that you're getting done with your initial chemotherapy treatment with your primary oncologist. For your myeloma, they're going to retest your disease. They're going to look at your lab work, 24-hour urines, repeat your imaging, and a bone marrow biopsy. For the transplant specific testing, they are going to look at your heart and lung testing. This could be in the form of an echo, an EKG, stress testing, pulmonary. All of this is done to ensure that you, your disease, and your body are in the best shape possible getting ready to run into transplant. So this is the safest transplant for you. Your team may ask you to get dental clearance. The reason for this is to ensure you have no active abscesses or infection happening within your mouth, and that can happen with your regular dentist. Sometimes this does take a little bit of time to coordinate, and especially if your dentist needs to do any additional work. So try and get this done early when you're asked so that you have the time to complete it. You will also be meeting with several folks that will be giving you education, such as your case manager, the pharmacist, your social worker. After all of your testing is completed, they're sent over to and asked for insurance approval at that time. Things to think about as you get ready for transplant is preparing for that initial consult appointment with your transplant physician. This is a big appointment, and you want to ensure that all of your questions are answered. Please write down any questions you have ahead of time and bring somebody with you if possible, because more sets of ears are always really great. That way everything is understood. Insurance authorizations will be talked at that point. And then you want to think about who you can pick to help you to be a caregiver. This could be one or two folks. As you start to think about taking time off of work, this is important for both you and your caregiver because you'll both need to be off for a significant amount of time. Your team can help you with any medical leave paperwork, but always try and get that to them ahead of time so they can get this done in a timely manner. Think about being away from home. Who's going to take care of your pets, get your mail, do your yard work, all the things you don't want to worry about when you are in the transplant process. And then you want to think at the same time about you coming back to your home and what you can do at your home so that it's ready for you so you can be most comfortable when you return. We have a lot of folks always ask us if there's any specific nutrition or exercise they can do to get ready. The best thing we always say is just a nice clean diet, do some low-level exercise, some walking. That way you are ready at your strongest point for this process. As you can see, there's a lot of dots on the screen. Your transplant team is a big team, and they're all here to help support you. You will meet a lot of folks along your way, and they're all there for you. Picking a caregiver. They're going to ask you what's their job to help you along the way. You're going to have a lot of fatigue after transplant. They're going to be there to help you with your basic needs, getting you up, getting you over to the restroom, helping get your shoes on until you find your strength. But they're also going to be there to help with your meal preps, help you make food, getting enough fluids. Eating food and having fluid intake are all the things you're not going to want to do, but they're going to lovingly encourage you to do it along the way. They're going to help provide transportation to the hospital to and from appointments. And we like our caregivers to help with the medication because when you're fatigued, you can't always keep up with which medications you've taken, when you can have your next one. It's good to have a team partner for that. Helping to assess you and communicate with your team are very important things. They go hand in hand. Your team is going to be talking to you and your caregiver about things that they're going to want you to be called in for. Do you get a fever? Are you not keeping enough food and fluid down? These are the things your caregiver is going to want to call your medical team about so a plan can be made. They're also going to be there to help you. This is an overwhelming time. They're going to be there to help give you some emotional support. And at times, you're going to need their help 24/7. You will be getting an IV catheter during this process. Your team's going to talk to you about what kind of catheter that you're going to get and at what time points. You could have this catheter for up to a month if it's the type that you get prior for stem cell collection, and then you can have it for your chemo, transplant, and time afterwards. Apheresis is the fancy word for stem cell collection. I gave you a few pictures because sometimes that always helps the process. In prep, you'll be given growth factor injections. Your body makes stem cells, but we're going to ask it to make a lot more to help so we can collect them. You'll get that IV catheter placed like we talked about. When you're on the collection machine, you could be on there for 4 to 5 hours, and it could take anywhere from 1 to 3 days. Your caregiver can be there to help support you during this process. Bring something with you because sometimes those 4 to 5 hours go on a little long, so bring a book or a crossword. We do like our patients to eat prior to collection. They just feel a little bit better. You can also bring snacks with you. When you're done with the completion of collecting your cells for the day, your medical team will be connected with you to let you know when you've completed enough cell collection or if you need to keep collecting. After you do collect your cells, we'd like you to go get some lunch, have a nice dinner, drink a couple extra glasses of water, take a good nap to help replenish you. The chemotherapy that you'll get prior to transplant is called melphalan. This is a one-time chemotherapy dose. You get it along with some IV fluids and medications for nausea. We have our patients suck on ice chips while they get their chemotherapy to help prevent mouth sores. Your team will be talking to you about the process when you get your chemo. The melphalan does a really great job of seeking out the cancer cells within your body. These are called plasma cells. But it also does a really great job of seeking out your good cells, your red cells, your white cells, your platelets, and does some harm to them. That's why we need your stem cells in the freezer to be able to give right back to you to help recover your bone marrow. For your transplant, this is given to you. Your cells are returned back the day after you get your chemotherapy. Some institutions do this as an inpatient setting. Some do it as an outpatient. Your medical team will be talking to you about this. The important part of while you're in your immediate post-transfusion period, be out of bed more than you're in it. If you can get up and do some walking, if you can be up in your chair, those are all important things to help your strength. You will find a time when your counts are low and your body will need the rest. Listen to your body when you need to rest. When your counts are low, you're going to have fatigue. During that fatigue time point, you are going to have some excessive dizziness, lightheadedness, just the extreme fatigue. During that time, it's really important to ask for the help when you need it. We want to avoid falls during this time, especially when you're getting up to the restroom. You will get lots of supportive cares for medications for the effects of the chemotherapy on your GI system to include heartburn, nausea, vomiting, diarrhea. Nutrition and fluid intake are important during this time. Even though you're not going to feel very hungry, it's important to be a grazer and just have little snacks every couple of hours just to help your GI system keep moving during this time. The chemo also makes all of your food and fluid taste metallic-y. You're going to have that tinny taste for about a month after your chemo. It will get better, but initially you will really notice it. You will have hair loss about 10 to 14 days after your chemotherapy. It does grow back, but you will notice that in those initial 2 weeks. Taking care of your mouth. Your lips and your mouth will get very dry during this process. You'll need a good lip balm. You may need lozenges or ice chips for sucking on. Let your medical team know if you start to notice any sores within your mouth so they can help you treat it. Infection prevention is very important during this time period. They will be having you do special processes for your oral cares and possibly showering with special soaps, all to prevent infection. Immediately when you discharge from the hospital, you may get to return home, or you may be required to stay within a certain amount of time from your transplant center. Your medical team will be talking to you about this on where you'll be staying. You'll still be recovering from your fatigue. You will still need supportive cares for your nausea and diarrhea. Encouraging those small snacks and meals for you to be that grazer. You will still have that tinny taste when you eat and drink. Hydration is key during this time, and I can't support that enough. It's really important for you to drink enough fluids. Having soups, jellos, popsicles all count in your hydration. Your medical team will talk to you about how much they want you to drink during this time period. Keep your walking going because you want to maintain your strength during this time. You'll be returning to the hospital for scheduled appointments and labs to check to see how you're recovering or if you need any infusions. Your medical team will talk to you about when to call for any concerns. Remember that skin, your mouth, your lip care, as they'll all be recovering. And remember to listen to your body and rest when you need it. When you talk about returning to home, it's good to remember that you're going to have some good days and some not so good days. The good days will start to outweigh themselves, but it's all due to your fatigue and recovery during this time period. The same important things to remember: doing your walking, your nutrition, your fluid intake. As we talked about, you're going to have more energy times than others. Kind of think about your household chores during this time. When you have more energized certain periods, that's the time that you'll want to do your household chores. Your dishes, thinking about some laundry, but space out those chores so that you don't get too overwhelmed and fatigued. Your pets, kind of think about who can help you out during this time to help you clean up after your pets. You're there to love them during this time period, and they're there to support you. Visitors are important, but we really like healthy visitors. If anybody's not feeling well, we'd rather them just make a phone call to you. As your immune system is brand new and recovering, we want to help support it. Your medical team's going to talk to you about how you're going to integrate back into your community with that brand new immune system. 100 days after transplant is a big time period for everyone. You did a lot of hard work. It's important to remember how proud everyone is of you during this time. They are going to restage your myeloma. They're going to look at your labs again, your urine, a new bone marrow biopsy, and an imaging. It really does take that long for the bone marrow to tell its final story and see what the effects of the transplant are. Due to that brand new immune system, you're going to repeat all of your childhood immunizations, and your medical team is going to give you a schedule to go over that with you. Your hair is starting to regrow during this time, your energy is improving, and you're starting to think about going back to work. Usually by this point, people say they have about 70 to 80% of the energy they did prior to transplant, and then it takes about the next 3 months to get that final push through. Just know this is a big time period and your medical team is there to celebrate it with you. So congratulations. I'd like to pass it on to my next team member.
Thank you, Jennifer and Dr. Angelo. You guys really painted a very interesting picture with regards to CAR-T as well as going through a stem cell transplant. And so for me, just to provide a little context, I was diagnosed in July of 2021 with multiple myeloma IgA kappa P17 deletion with 2 submutated genes, which categorized me as being high risk. From July to October, I went through 5 days of treatment, Monday through Friday, for 6 to 8 hours per day, burning about $22,500 per week. I managed to achieve remission in October of 2021, stem cell transplant of February of 2022, engraftment syndrome in in March of 2022, and achieved 100-day recovery roughly in May of 2022. Since I started my diagnosis and my treatment, I've incurred about $2.65 million of overall cost, much of which I didn't pay for, but certainly I would like to talk to you today about how to avoid the financial toxicity and the burdens that go along with being diagnosed with cancer. So just like an earthquake causing a tsunami, the financial toxicity that comes along with terminal illness or severe illness can indeed wreak havoc on your family as well as your lives. Financial toxicity is a term used to describe the financial side effects induced by cancer treatment. The term was coined in 2013 by researchers at Duke University. It is also known as financial duress, financial stress, financial hardship, and in accordance to the Institute of Medical Report, the costs of cancer treatment are escalating substantially, making it far less affordable for patients and their family to deal with the overall toxicity of cancer care. So what are some of the factors? The most common factors that are contribute to financial toxicity are the overall cost of the treatment, as well as dealing with the medical provider, the high cost of the inability to work, the additional transportation, medical expense costs, childcare costs, home mortgage, the list just goes on and on. And what I'd like to say here is if you can just imagine that you're living your life and the rug is pulled from underneath you and your expenses of what you require to make per day are taken away from you, you are on the early stages of dealing with financial toxicity. So based on the study research, about 90,000 patients that were researched under the medical expenditures, average work days missed were about 22.3 work days per year. In my case, I missed somewhere in the neighborhood of about 180, almost 200 days because I had no ability to work and at that point in time, no income. Healthcare costs related to cancer can lead to asset depletion. In my case, as far as my wife and I, we fell into this statistic. Certainly, even with insurance, we still had out-of-pocket expense along with travel costs and other additional costs for which our insurance didn't cover that we certainly had to deal with and consult with during our particular diagnosis. 25% of the patients understood that their out-of-pocket expense would be incurred. An additional 66% responded say that they did not remember having any explanation provided to them before their treatment. And in my case, my doctor alluded to, Mr. Proctor, you just need to trust us. Mr. Proctor, we're going to get you better. And certainly you put a lot of effort, time, and energy into paying your insurance premiums and listening to your doctors and hoping that this financial toxicity or additional costs doesn't weigh heavily against you. So as we know from 2022 as well as 2023, cancer continues to be on an uptick. In the case of multiple myeloma, there's about 40,000 newly diagnosed cases per year. Surviving cancer requires more than just medicine. It requires families. We also need a roof over our head. We need food on the table. Patients who receive financial intervention typically have about a 73% survival ratio compared to only 46% of those who do not. So what steps do we need to take, particularly as a newly diagnosed patient? The immediate actions to address financial concerns upon diagnosis is to gather all of your financial documents, insurance policies, medical bills, statements, and take a good hard assessment and understand where your financial picture is as of the diagnosis. Explore financial assistance programs, which there are multiple financial assistance programs nationwide as well as locally. Look at housing and rental programs and mortgage relief programs, which can also offset some of your financial expenditures on a monthly basis. Communicate with your healthcare provider about your financial concerns and seek guidance. One of the things that was so pivotal for myself as well as my family is looking at our assets and understanding that we needed to ensure that coming out of the circumstance of dealing with all of the financial burden is that we would not carry any debt. And so things that we looked at were if we had assets that we were no longer utilizing or assets that were no longer of value to us, we relinquished those or liquidated those assets. We also looked at, in one particular instance, selling off one of our life insurance policies to kind of help allow for us to reduce some of that cost. So there's a tremendous amount of opportunity out there with regards to looking at your financial picture and assessing your situation, because each situation in each case is rather unique. For currently diagnosed patients or existing diagnosed patients, the importance of ongoing monthly reviews of your cost expenditures, looking at your insurance during renewal periods to find the best possible benefits to ensure that your coverage will be met, or excuse me, your coverages will be met. Tracking your medical expenses and maintaining comprehensive records, as well as seeking advice to develop a realistic budget to maintain your expenditures. So in summary, in facing financial toxicity, let us remember that our strengths not only lies in our ability to overcome our challenges, but also in our determination to prioritize our well-being and to navigate this journey with resilience and hope. And what you see off to the left-hand side there is a recent bill of my treatment, which was $22,517 for that single treatment. And here I've provided some resources, drug assistance programs, as well as websites of different local and national programs that provide grants and assistance for newly diagnosed patients as well as existing patients. And so now I'd like to turn it over to Mr. John Murphy.
Thanks, Gregory. Now we get to our question and answer portion of the webinar. First question is, CAR T is so expensive. I guess this is for Dr. D'Angelo, although anybody can jump in if you like. When it becomes more available down the road, will the cost decrease, do you think?
Yeah, that is a great question and a wonderful point. CAR T cells are expensive. The sticker price that you might hear about it, if you Googled it, is about $500,000, a little bit less for that, just for the CAR T cells. And that doesn't even include the care that surrounds that, the hospital stay, if you're hospitalized for CAR T. I don't know. I think as manufacturing principles get better, cost could come down a little bit as manufacturing gets more efficient. That's a very possible thing. However, I'll also say, the way that we pay for, at least in the United States, the way that we pay for drugs and therapies in our insurance and our very complicated health insurance environment doesn't necessarily translate into more competition, lowers prices. There's multiple examples of where having different versions of a very similar drug doesn't necessarily lead to lower prices. So I don't know. I am an optimist. I'm always an optimist here. And I think things will get a little bit better, but the way that happens isn't clear. And I think it takes some kind of larger governing level with how we pay for insurance to truly make changes in how we pay for these kinds of things, because they are accelerating at a sort of unsustainable pace. Now, I say all of that, but I also want to say CAR Ts are expensive, but they are a one-time therapy. And so when we're thinking about myeloma therapies, the additive effect, revlimid is one of the most expensive drugs that's available on the market. And as patients are receiving that daily and stuff like that, that cost can over time increase. So, pound for pound, there are advantages to CAR T in that sense as well. Though I don't know if my other panelists have any other thoughts on this.
My only comment to that, if a patient is looking to go into CAR T, would certainly be to contact their insurance company and basically understand what coverages are allowed. It's very important not to just take the summary for granted when you're dealing with a terminal illness or severe illness, because it's very important to understand what your coverages are so that you lower your overall out-of-pocket expense.
And as Gregory's mentioned before, your insurance takes the brunt of it. And if there is something, if they're giving you an out-of-pocket quote that is not, suitable, absolutely let your doctor know and your medical team know, because there may be options that are available to help with that. All of those resources that Gregory provided are good examples.
Second question is, can you please tell me about the first-line chemotherapy for multiple myeloma? And I guess that's in relation to or anticipatory to CAR T cell therapy or stem cell therapy.
Mm-hmm.
Yes, I would say, I mean, the standard of care, at least in the United States, is changing. And for a long time, it was what we called a triplet therapy, including Velcade, which is a shot. Bortezomib is its other name. All drugs have two names, unfortunately, just to make things as confusing as possible. Revlimid, which is a pill and also known as lenalidomide, and then dexamethasone or steroids. More recently, we've begun to incorporate daratumumab, which is another, in general, for the most part, a shot that's given. It can be given as an IV as well, but for the most part, it's given as a shot. We've added in that daratumumab drug and sort of are pivoting a little bit more towards quadruplet therapy, or 4 drugs to start. Whether or not one patient gets 3 or 4, it depends kind of on what's going on, because there's other factors that when myeloma is initially diagnosed that might influence why your doctor would select one regimen versus the other, depending on kind of other things going on. I would say in general, the initial diagnosis and treatment is hard because, oftentimes patients are feeling their worst by the time that the cancer is diagnosed. Now, everyone's journey starts differently. Some people, it's detected on routine blood work. Other times, it's detected when someone shows up after breaking a bone, and then you find that there's a cancer there. So, sometimes those early weeks after treatment can be different depending on what the myeloma is doing at the time you're diagnosed. But I would say in general, what's nice about these drugs is as we've learned more and more about them, they tend to be pretty good as far as side effects go. The main side effect that often comes up is the neuropathy with the Velcade shots. And that's something to let your doctor and your treatment team know about quickly, because if that's growing, that can lead to us, that's getting worse. And I'm talking about numbness and tingling in your hands and your feet. If that's growing and getting worse, best thing to do is kind of trying to adjust therapies and keep that from getting too bad, because that can take a long time to recover.
Yeah, certainly great points there, Dr. Angelo. I'm currently still on my first line of treatment, which is the Darzalex, Velcade, and dexamethasone, which is proven to actually be quite beneficial for me with minimal side effects.
Okay, our third question, we're not supposed to answer about specific cases, but I think this will be okay. Would high risk and extramedullary multiple myeloma be a good fit for CAR T?
Absolutely. These therapies, high risk multiple myeloma traditionally means that, if you respond, maybe you're a little bit less likely to respond, or if you respond, relapses may happen sooner compared to standard risk, but not necessarily. And I think that that's really important. And as we're studying new immune-based therapies like CAR T, the answers are becoming a little less clear. I can tell you we've absolutely seen treated patients with high-risk myeloma that have had fantastic responses to CAR T. So again, being an optimist here, absolutely, I think that would be a good fit for CAR T.
Okay, I think this is for Jennifer Schmidt. What is the risk of giving bone marrow transplant to a patient with a history of heart surgery? And I have a question that tags onto that. Just in terms of terminology, is bone marrow transplant considered the same as stem cell transplant in terms of
Yeah.
multiple myeloma?
Go ahead, Dr. D'Angelo, you can answer that part.
Oh, short answer is yes. Bone marrow transplant, stem cell transplant, hematopoietic bone marrow stem cell transplant, all talking about the same procedure. And as far as heart health goes, I think if it's been we will evaluate your heart function ahead of transplant. If we had any concerns, we would be looping your cardiologist in. If it's a fresh, like within the last year heart surgery, as long as you're doing well without any symptoms, we would talk to your cardiologist. And if he didn't have any concerns, we'd go right ahead with stem cell transplants. I can tell you in general, your other parts of your medical team, as Jenny showed a wonderful slide of the people behind the scenes, everybody wants to put you in as good a shape as possible, and nobody wants to get in the way of your treatment for myeloma. So we all work together on that.
Okay, so next question is, my father is not a U.S. citizen and doesn't live in the USA. So is it possible to enroll him for CAR-T or stem cell with a financial waiver? Again, we're not supposed to comment on specific cases, but what if you don't have any insurance, Gregory? Is there any resource for you?
The answer is yes, John, but it certainly requires a tremendous amount of legwork to find those within your local regions as well as your national chapters. And the reason why I'm saying that is because no one's going to cover you for, let's just say hypothetically, $1 million. You may get 15,000, you may get 12,000, but you're going to have to continuously work at trying to find those sources of grants or funding sources that most foundations or societies can offer for newly diagnosed, or in this particular case, CAR-T. Occasionally, from what I've seen through my own research, there are instances out there where, and I'll say this very loosely, where maybe you can use a GoFundMe to kind of raise capital for being in a situation without insurance. But there are resources out there. There's plenty of information out there on the web. Certainly, it's very hard to find and navigate. And I want to say the last important piece here is, besides qualifying, is getting in your application soon enough so that you're able to reap some of the benefits. Because in most cases, if there is free money available, it does run out very quickly.
Okay. Next question is, what are the current recommendations for CAR-T? Do you need to have a previous transplant or two? Also, how is the CAR-T, how do the pros and cons look in comparison to stem cell transplant currently? Are they one for one? Is it either CAR-T or stem cell transplant?
CAR-T cells, let me know if I didn't answer all of this. CAR-T cells are usually after stem cell transplants. You do not have to have had a transplant to be eligible to receive CAR-T. If your doctor said you weren't eligible for stem cell transplant, you may actually be eligible for CAR-T cell therapy. So feel free to ask them about that. Mostly we're limited right now by what we call number of lines of therapy. Excuse me, stem cell transplant tends to be considered as part of your frontline therapy and isn't a separate line. Excuse me. CAR-T and stem cell transplant haven't been compared head to head yet, so we don't prefer one or the other right now. However, that is an excellent question, and that's one that we're testing right now. We currently have trials that are underway right now, starting to take a look at newly diagnosed myeloma. Should we randomize people to a CAR-T or to a stem cell transplant and see which ones work better? Now, I say that with, as much as CAR-T is the new kid on the street, or new kid on the block, so to speak, transplant's been around for a long time for a very good reason. It works. Every time a new drug has come out for myeloma, we've asked, well, I wonder if we still need to use stem cell transplant. And that question's been around for the last 20 years or so. And every time we look, we still see that transplant helps. So it's definitely not fit for everybody. We want to make sure you're in good shape for that. And maybe what we'll learn first is the people that we think weren't as great of stem cell transplant candidates. Maybe one day we'll offer them CAR-T instead. But until then, I'll tell you, there is no therapy in myeloma that buys the years of disease control that a stem cell transplant does. So for right now, and this is a question that even myeloma doctors are actively asking each other and stuff, I'm very pro transplant, and I'd say it's a very effective therapy.
May I chime into that also, there,
Oh,
John?
I'm sorry. Please do. Yeah.
You know, from a patient perspective, at least for me, I was very reluctant, certainly in the early stages, because as you're diagnosed, not only is your life flipped upside down and the tsunami comes crashing over you, but you're trying to learn all of this new terminology, drugs, and so forth and so on. So for me, the first phase of just getting through and getting the disease eradicated and abated was kind of the first step. And then stepping into the transplant was something that I was a little apprehensive on, but I think from the standpoint of communicating with groups and other doctors and figuring out, you know, the positives versus the negatives, the pros and the cons, it kind of subsided some of that anxiety and concern that I had. And I must say today, you know, being almost 2 years since my transplant, it is probably the best thing that has helped me recover as quickly as I have.
Okay.
Please feel free to chime in anytime. Your experiences and your advice and counseling is really wonderful to have on here, Gregory.
Thank you, Dr. Angelo.
A patient asks, I'm currently using water aerobics 5 days a week for an hour. Is this an acceptable exercise after I return from stem cell in lieu of mall walking?
Well, no,
Go ahead, Jennifer.
Yeah, getting back into the public pool initially, your medical team will kind of give you some guidance on that one. If it was your own personal pool, yes, you would know who else is in there with you. Just with that brand new immune system, they're going to want to limit you from the public pool situation. I love that you're doing all of this workout ahead of time, because that will make you so much stronger going into the transplant period. Your initial exercise coming out will be more limited to just yourself. Even mall walking, I kind of hold with that one for a while too. Walking just around your block is it's just you, it's by yourself, you're breathing in your own air, you're exposed to less other folks until you have a stronger immune system.
Okay.
Yeah, John, if I can just chime in just a little bit more on that, at least from my own experiences, I was diagnosed during the COVID pandemic. For me, my wife and I just kind of looked at everything that was off peak after my stem cell transplant. You know, instead of going to the grocery stores and things on the weekends, you know, we would mask up and do those like on a Wednesday. You know, so as Jennifer has alluded to, keeping yourself completely isolated. I use this term loosely, kind of, I was like the boy in the bubble, you know, after my transplant, trying to make sure I didn't have any other interaction with folks that you may not know where they come from or who they've been in contact with, just until your immune system gets rebooted.
I have a question. When someone gets a liver transplant or a kidney transplant, there's the danger of that it will be rejected by the body. Is there a comparable rejection possibility with stem cell transplant?
There's the usual transplant we use is something that we call an auto stem cell transplant, which are your stem cells that are put back in. And no, there's no chance of that being rejected. Now, sometimes the opposite can happen, particularly if you do so. So Gregory mentioned engraftment syndrome, which is a little bit of your new cells coming in and getting a little fiery, so to speak. I don't mean to minimize that condition. Allo transplants, when a donor immune system is introduced and donor stem cells are introduced in your body, can cause something called graft versus host disease, which is the opposite. It's not your body rejecting the graft, it's your graft rejecting the body. Now, we don't really do allo transplants for multiple myeloma. They do happen. They're just rarer.
Okay. Here's a financial question. Some hospitals have programs for coverage of financial debt after Medicare and insurance coverage. Are there similar programs available to assist patients financially countrywide? What programs are available?
There are programs available. Certainly, as I mentioned, you certainly want to check with your social worker or your financial administrator with your hospital. That would be the first thing. From an insurance perspective, if you are not covered completely with your insurance, again, there's local, regional chapters. One would be certainly like LLS as an example. They offer different types of funding source that are out there for different scenarios. There's Fund Finder as another website for different types of cancer, including multiple myeloma, where you can go and find different sources of funding. So the funding is available. And I guess I didn't emphasize this point clearly enough. It is a full-time job when you're diagnosed to find those resources that are needed, particularly if you are in a despaired or financial difficult situation, or you can't work. Like in my case, I could not work. I couldn't work for like a year. You have to be diligent. And the number one question I asked myself was basically, I want to live. And so if I want to live, then I'm putting forth the effort that is needed to try and seek out those things that are available. But they are available, John. And some of those are on the list that I provided.
Okay. Gregory, that makes me think of a question for you. If you're a homeowner, you have homeowners insurance, and a tree falls on your house, instead of dealing with the insurance company directly, you can call up a public claims adjuster who can work on your behalf to negotiate with the insurance company. Is there anything like that that you're aware of for health insurance where someone can do some of the legwork for you to get a better, to negotiate with the insurance company?
The only way that can happen is certainly if they're on the policy or if you have a designated power of attorney. In most cases, it's going to be you, the primary healthcare recipient, that will have to deal with the insurance company. There's so many variables that I discovered through my own personal cancer diagnosis that I was just unaware of, particularly as it relates to one instance of understanding what the insurance covers, because they send you a summary. And of course, I had to basically ask for the full contract. And what you begin to find out in the full contract is these are things that they will cover under a hospital parameter, but they won't cover them on a referral parameter. So it's all these little details that you must dive into whatever your coverages are to fully understand whether or not you can weather the storm going forward.
Gregory, is that something you can do? Are you saying that's something you can do before the procedure? Like as if you take your car into the mechanic and he can give you an estimate of all the things you might need and what's covered?
Well, John, I'll tell you, if my doctor oncologist, and I'm sure she's probably going to listen to this at some point, would have told me what the cost was, I probably would have passed out. I was already in a state of shock as it was, just having the words, "You've got cancer and please get your affairs in order." The answer to your question is no, because there's so many different, as Dr. D'Angelo and Jennifer have alluded to, there's so many different variations. And, with multiple myeloma, at least for me, I discovered the parameters of, I've got IgG or IgA, and there's all these other different parameters. So every doctor is going to approach it differently based on, what your body can handle. And, for a standpoint of trying to understand what your cost implications are going to be, I mean, it's almost like playing roulette. I mean, you just never know. I didn't know what my cost expenditures were until my insurance company called me and said, "Mr. Proctor, you've reached your ceiling." And at the same time, my doctor said, "Mr. Proctor, we've got a bill here of $250,000 that your insurance company hasn't paid." Trust me, I began to freak out at that point and really got into scramble mode to really understand how can I divert some of this cost away from my own personal back pocket and into other means that would be able to help me out.
Okay. All right.
Quick comment on everything that Gregory has been talking about. Don't hesitate to inform your medical team about concerns about financial toxicity. We can help in ways that you may or may not be aware of. Sometimes we're choosing between options that we think are maybe equally effective, and one is a whole lot cheaper. And there's lots of decisions between this, or maybe one is way cheaper, maybe slightly different in its side effects or how it's delivered or stuff, but maybe that's the right fit for you. Because at the end of the day, your team that's taking care of you treats you. They do not treat the disease, they take care of you. So if we've made the numbers look better or have shrunk the mass, but have left you financially wounded or with other side effects, well, that's not a win. That ain't cutting it. We're not winning until we've cured this myeloma and left you in good financial shape and minimizing those toxicities, financial toxicity, one of them. So don't hesitate to bring that up, because we might have more things available to treat you.
Very good point.
You mentioned something like the best treatment for CAR T-cell therapy is the one you can get. If you're looking, if your doctor recommends you have stem cell therapy or CAR T-cell therapy, where do you go to get it? Can you shop around? Can you get recommendations? You know, what's your next step?
I think you could talk to your doctor about what they would suggest, where they would suggest to go. You know, unfortunately, not every patient lives and has as good of access to other CAR T centers. And I wish we had better access to this. This is something that we think about as myeloma doctors, as researchers and things. And this kind of contributes to that financial toxicity too. Some people that have resources are able to hop on a plane or rent an Airbnb and stay near a CAR T center if they're not near one, and can try at different places and stuff. You don't, to be treated at Nebraska, you don't need to live in Nebraska. You don't need to live in Iowa. You can live in Florida, you know. And then with some of the caveats of inside the United States versus outside the United States, it gets a little bit more tricky, but those are some options, and you're not restricted to just one center.
Okay.
There's 2 minutes left. Should we do some rapid fires, John? Or?
Yeah. As a matter of fact, here's one right now. Does revlimid contribute to peripheral neuropathy?
In general, no. Sometimes maybe. I think it depends. If I was seeing you and wondering if it was revlimid or not, I think it might depend on whether or not there's some antecedent neuropathy. If you didn't have anything and then we put you on revlimid maintenance as an example, and then you develop neuropathy, I might be willing to say that. If you look in the background, if you looked at, like, Googled revlimid neuropathy or something and someone said there's a small percentage of it, sometimes it can be tricky to tell, because revlimid was often given with Velcade, and Velcade absolutely causes neuropathy. And if you're trying to determine which one caused it, sometimes it's hard to tell. So then you kind of list both. A sort of longer answer.
Okay. Another rapid fire question. Can you do stem cell transplant after CAR T?
Theoretically, yes. In general, most of us won't, because in later lines of therapy, stem cell transplant doesn't seem to be as effective. I saw one question about T-cell exhaustion that I just wanted to address quickly. That is a wonderful question. It is an open area of research right now. We're trying to figure out how to make that better. T-cells are exhausted for a variety of reasons. Sometimes just major amounts of tumor, of cancer in the body can exhaust T-cells. So lowering that and getting better disease control can invigorate T-cells. There are some drugs that we're actively investigating that seem to better stimulate T-cells. Revlimid is a great example of that. Revlimid works in a lot of different ways. One of the ways it seems to be is immunomodulatory, meaning it can kind of improve T-cell responses. And we're actually doing trials taking a look at giving Revlimid ahead of CAR T to see if that helps improve it, or giving it after CAR T. And as those cells are in you, seeing if we can do things to boost it. Lots of other different ways we're looking at this too. Lots of different research opportunities. We're looking at nutrition, at the gut microbiome, if you've heard of it, of ways to kind of improve our immune systems. I don't have great answers for you yet, but it is a great question, and it is one that we're looking into. As far as consecutive anti-BCMA treatments, a couple of people have asked about this. In general, if you can avoid anti-BCMA therapies ahead of your CAR T, we tend to recommend that. Sometimes if that's just what we need to do to get control of your disease and to get you to CAR T, well, then it is what it is. And we've seen people get anti-BCMA therapy that then get anti-BCMA CAR T that go on to have wonderful responses. Some of the research suggests that CAR T can be a little bit less effective if you are exposed to anti-BCMA beforehand, which is why sometimes myeloma doctors have a little bit of pause about BCMA therapy ahead of CAR T. Absolutely, you can use it after CAR T, and I think it will work. And in general, it has worked. This is an active research question, too, of how we sequence these therapies.
Okay.
John, I see one here just very, very quickly. Someone had asked, does BMS or Janssen have patient assistant program for CAR T? I just want to kind of expand upon that. Every pharmaceutical company is going to have some type of financial assistance program. And the one thing you don't want to do is not ask. So if you're going to advocate for yourself, I would highly, highly advise ask those questions to avoid the financial toxicity and to avoid some of the long-term adverse effects that may come down the road. But certainly every pharmaceutical company that I'm aware of has some type of drug or patient assistant program that is readily available for individuals that are newly diagnosed or existing patients. I just wanted to clarify that, John. Sorry.
That's a very good point. I'm afraid that we've run out of time here, so we have to call it a day.